Well, hello everyone, and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thank you for joining us. My name is Elisa Warden-Kirwak. I am a senior healthcare interior designer here at Gresham Smith and Partners, and one of your co-hosts for today. It's a pleasure to introduce Dr. Robert White, my co-host, who will be leading today's discussion with Dr. Sheila Bosch. Dr. White has been director of the Regional Newborn Program at Memorial Hospital of South Bend, Indiana since 1981. Dr. White has had a long-standing interest in the effect of the NICU environment on babies, families, and caregivers with many publications on that topic. He is chairman of the consensus committee that develops recommended standards for newborn ICU design, co-chair of the annual Gravens Conference on the Physical and Developmental Environment of the High-Risk Newborn, and chairman of the International Conference on Brain Monitoring and Neuroprotection in the Newborn. He has appointments at the University of Notre Dame and the Indiana University School of Medicine. And with that, I'll turn it over to Bob, who will introduce you to today's guest author. Bob?
Thank you, Lisa. And once again, welcome everyone to today's Evidence-Based Design Journal Club. I'm Bob White. I'll be leading our discussion today with Sheila Bosch. As Lisa mentioned, we are hosting this event to identify the everyday practical applications of research findings in a published article. Today's featured article is Staff Perceptions Before and After Adding Single-Family Rooms in the NICU. Sheila is the Director of Research for Gresham Smith and Partners, where she serves as a firm-wide resource for GS&P planners and designers as they apply research evidence to enhance quality, safety, and efficiency in healthcare settings. Sheila is a regular national speaker and author and a recognized expert in this field. She's an incoming co-chair for the Center for Health Design's Research Coalition. She's actively involved with the Academy of Architecture for Health Research Committee, and she's an incoming member of the Academy of Architecture for Health Foundation's Board of Trustees. Sheila, we're delighted to have you on the line with us.
Thank you, Bob. It's great to be here, and hi to everyone on the call. We appreciate you joining us today.
Thanks, Sheila. On today's call, we will have an active discussion about key factors in your study. We ask our audience to pose questions throughout the call today, and we will take time to answer them at the end. So please be sure to join in today's discussion by chatting in your questions or comments as they come to you. Sheila, could you set the stage for us by identifying why single-family room design has become popular for the NICU and what we know about its benefits and hazards prior to this study?
Sure, Bob. Well, I'll tell you, I had a baby in the NICU about 9 years ago, and it was an open bay NICU, and I got to tell you, it wasn't very private. It was sort of uncomfortable trying to breastfeed. So the single-family room concept has emerged really for a number of different reasons. One is that we have greater control over lighting and noise, too much of which are harmful for these infants. So we have better control of those unwanted stimuli, and we also have increased privacy. So the family members are better able to breastfeed, provide skin-to-skin contact, or kangaroo care. And we're also, it's easier to comply with the HIPAA requirements as well. And Bob, as a neonatologist, I know that you probably have some other things to add to that, perhaps.
Well, yes, there are a number of other benefits for babies, families, and staff members, but I think we can get into that with some of our discussion as we go along later. I think your study has opened up some key areas for discussion, though. So could you tell us how the study site you chose was an ideal one to advance some of this research a little further?
Sure. Well, what we did was we designed an addition with 23 single-family room NICU to an existing open bay. So the total bed count is 64 beds. And what was beautiful about this site is, well, first we had a willing and excited and interested client. So they were already investigating staff perceptions even beforehand. So with this site, we're able to look at the pre-move condition, which is open bay only, and the post-move condition, which was a combination of the open bay and the single-family room. So it just provided a really nice platform. And what we did was we used a survey method, pre-move and post-move into the new addition, to really gauge staff members' perceptions about a whole host of attributes like staff stress, uh, ability to respond in an emergency kind of situation, all kinds of different variables that we were able to look at.
Okay, let's look at your specific objectives. You've kind of identified that in general. Can you talk a little bit more about the two specific areas and two specific populations you looked at?
Absolutely. So we did conduct only a staff, so these are all staff perceptions, but we did ask the staff questions that sort of fell under two different headers, and one of those being the quality of the environment we provided for the staff. So what was the work environment quality? And then we also looked at the quality of the environment for infants and their families. As you can imagine, sometimes these might be conflicting, right? If the open bay might provide a nice place for nurses to have other staff members with eyes on their babies, so it might be better for nursing in some respects, but then for the infants and their families, what sort of impact does that have? So we looked at those two specific areas.
Good. So could you tell us a little bit about the hospital where you chose to do this study? What are the ways that you think this hospital were suited to your survey, and how representative do you think this Joe DiMaggio Children's Hospital is compared to other hospitals throughout the country?
Well, I tell you, Bob, we are seeing, particularly here in the Tampa area where I am, and most of the projects, the NICU projects that my firm has done in recent years, we're really seeing the addition of single-family rooms or a complete conversion from open bay to single-family rooms. So we're seeing a bit more of that. But I do understand that hospital reimbursements are declining, and there are lots of factors that seem to, that affect initial costs and operating costs for that matter as well. So we, I don't know, what is your experience, Bob, in terms of what percentage of new facilities are doing single-family room versus the open bay of some sort?
Well, I think you're right that most people who can, if they have the space and the funding to do it, are going to single-family room design. I think this study is particularly helpful because you were able to talk to staff who were working in both settings simultaneously. Some of the studies have been done before use historical controls, and having these staff who have experience in both areas give you their feedback is, I think, relatively unique, and you did give us some additional very valuable information from the study. So tell us a little bit more about the layout of the Joe DiMaggio unit, if you will.
Sure. Let me show you the, well, this is the exterior of the addition, so just a nice view there. Half of the single-family rooms, approximately, have windows. They're on this exterior wall, and about half of them don't. Let me tell you a little bit about the hospital. This particular addition was open in May of 2009. It is a level 3 NICU, and I did mention that there are 64 beds total. So here's the floor plan. Now, I know that it's really hard to see all of that on your screen, but what you'll see there in all the beige, the beige sort of in all the perimeter, the exterior portion is the addition, and then there was renovation accommodations indicated by the beige areas there as well. And let's see, I'm trying to think there, of course there's the medication room and supply room and all of those other things that you would expect to be on the unit are there. I'm going to show you guys a couple of images, very colorful. This is an image looking where, so you see the centralized nurse station there, but also there are decentralized little workstations between every 2 patient rooms, so that to try and increase visibility. Certainly that was one of the biggest fears of the nursing staff, was a reduction in visibility. So we tried to address that with the decentralized workstations. And here's one of those, just sort of up close. And actually from folks, I hear from other projects too, that actually if these can accommodate 2 people, that's really ideal, because that allows nurses to give reports easily and that sort of thing. And they can collaborate with one another. And then this is just a typical room here. You can see the head wall and the foot wall. And now this one here is showing a bathroom, but most of the rooms do not have a full private bath. And here's the room. So you can see this is one of the daylit rooms on the exterior, and they're spacious. They have the family zone, the sleeper sofa, all those things that you might expect in a single family room. What else,
Okay,
Bob?
so you did a survey. You talked to nurses both before and after this new area was opened. And what did you find?
Well, it was really interesting, Bob. The survey had 30 questions on it, and what we did was an analysis for each of those questions. And we found that the nurses, although they expressed a lot of concerns pre-move about all kinds of things, like I mentioned, the being able to observe each other's infants, the sense of teamwork, maybe a reduction in socialization. There were a lot of fears expressed prior to the project. But honestly, I was surprised when we found that 21 out of those 30 items were rated better for the combination NICU with the new abortion. And those other items, they remained unchanged from a statistical perspective. So yeah, we did expect, some improvement, but I actually was surprised that there was such a strong, statistically significant finding for all those items. Now, we also found that the staff, here, let me tell you this little insight. This is kind of, oh goodness, the trials of a researcher. So when we submitted the IRB, or the Institutional Review Board application, for which we did ultimately receive an exempt review, we didn't include informal staff interviews on the IRB application. But I thought once this was going, I really should go down there and chat with some of these nurses just to see how things are working. And so the informal interview piece was not part of it, so we couldn't publish that piece. But actually, some of the nurses did express concern post-move about the safety of the infants. They felt like the sickest infants were safer actually in an open bay environment where their other team members can have an eye on their infants. So it was very interesting that the survey was 100% almost, satisfied, and looking at the statistical significance to the P at 0.05 level. But then some of the comments were a little bit contradictory. But what are you finding, Bob, in the studies that you've done in terms of having a combination unit versus all single family versus all open bay. Do you have any other insights into that?
Yeah, so there is a lot of question about safety, as your nurses noted, even after they were in this setting. I can tell you that there have been a couple of studies that looked at that specifically and showed that there was no decrement in safety for the kids who were in the private rooms. In fact, several of them have shown that the kids did better, that they were healthier. For example, a study from the unit in West Virginia that looked at this, Domenico is the first author of that study, published in Journal of Perinatology in 2011, showed that the apnea rate was much less for the kids who were in the private rooms than in the open bays. So this concern about safety is a very real one before you get into that setting, but I think the data shows that kids are in fact as safe or perhaps even safer in the private rooms. So Sheila, I think I want to take a break from our slides here for a minute. There were several questions that I'd like to get to. Let me scroll back to those and present them to you. Our first was from Kristen Palachak, who asked what was behind the decision to keep some open bay beds versus single-family rooms.
That's a good question. The way, well, based on the budget and also the building footprint, they weren't able to easily sort of reconfigure everything to all single-family rooms. So part of it just was based on that. I was not on the team when those sorts of decisions were being made, so I'm really speaking just with guesswork. I don't really know for sure if the desire would have been to go all single-family rooms. I can tell you now, though, after talking recently with the clinical manager there at the hospital, that she wishes they had all single-family rooms now, because there are actually some problems posed by having both. For instance, if you have a patient in the single-family, or the open bay rather, and they realize you have single-family rooms, they're going to demand it. They're going to ask for that. And here at DiMaggio, even with the private rooms, if a patient is placed in the room without a window, they're also requesting to be moved. So they actually wish everything was the same throughout the unit, would make their life a lot easier, and they'd have to transfer infants a lot less often from one room to the other.
Well, you just anticipated the next two questions that have been posed, so that was perfect. I do think, looking at your layout, that the only way they could have done single-family rooms for all of the beds would have been to reduce their bed count, because it does take about 20% more space to do single-family rooms, and their whole goal was to increase their bed count to where they were. So that, I think that had to be a big part of the decision, that they just couldn't do it and maintain the bed count that they were shooting for. Kristen also asked about something related to this. What was the construction cost difference between the single-family room and had they done open bay? Do you have a sense of that? And are there operational cost differences between the two?
Well, yeah, that's a great question, and I got to tell you, we have, I actually don't know for this specific project if they did a cost comparison for what it would be to do, 64 single-family rooms versus 23 in the remainder open bay. I do know that for a different project that we did, which was an addition, that we did compare the pricing for single family versus like 2 infants per room. And the cost difference there was so small that the hospital did opt to go with all single family rooms in the end. So it can be more expensive initially, of course, but operationally, that's another good question. some people perceive that, and I haven't seen a study on this, so I don't know for sure if in fact more staff time, more FTEs are required to run the all single family room. Probably if they're running at the appropriate ratios, it's not going to vary that much. But I do think there's a perception that it requires more staff to work the single family room. What have you heard?
Yeah, so let me provide some additional insight on that. I'm working with Blair Sadler, Mardell Shepley, and Judy Smith to write a paper that's tentatively called the Fable in ICU. Most of you are familiar with the Fable hospital that Blair and some of the other colleagues that you all have worked with proposed, and it is a hypothetical hospital, but they showed that by putting adult patients all in private rooms, that although there was increased cost, that was recouped within the first 18 months by reductions in falls and med airs and a variety of other savings. So we're looking at data that we have now from single-family room NICUs to determine what the Fable NICU would look like. And it looks like the construction cost is about 20% greater for single-family rooms, just because the minimum space requirement for a single-family room is 165 square feet clear, whereas for open bay it's 120 square feet clear. So you do have that increased construction cost up front, but, and again, we don't have this finalized yet. It looks like, again, you will recoup that within no more than 1 to 2 years on the basis of improved patient outcomes. And I'll just tell you a couple of examples of those. One is from the unit at Karolinska in Sweden, which showed that their babies under 30 weeks gestation who were in single-family rooms compared to a randomized controlled group that were in open bay rooms got out of the ICU 10 days quicker. So that's a substantial savings for every baby. Dennis Stevens in South Dakota, in an article that was published in Herd just last year, showed 15% savings overall per baby admitted to the NICU. So again, substantial savings, 2 studies that kind of back each other up on that. And although the operating costs are a little higher, just it costs more for heat and air conditioning for a little more space, the actual personnel costs are not substantially greater. So every time I go visit a single-family room NICU, I ask this question: did you have to increase staff? And virtually none of them have had to do so for nursing staff. Their nursing ratios remain the same. Their nurses do walk a little more, no doubt about it, but they would in a bigger, newer, more spacious unit, whether they had walls or not. The biggest difference for places that did need more staff, at Winnie Palmer in Orlando, for example, they have close to 150 beds in their NICU, and they had to put a new person on at the front desk just to direct people for how to find their baby. And at Dennis Stevens' unit, they needed a new support person because they kept a lot more of the supplies at the bedside because they had space in these private rooms to do that, and they had a person who was added to their staff to provide those. So those are not the highest cost staff. There are some staff increases, but again, compared to the savings and better outcomes for babies, the differences are definitely in favor of the single-family room. We do have some other questions. I'm going to, rather than get too far away from your study right now, though, let's move on to your conclusions and kind of wrap up your study, and then we can get back to these questions.
Well, yes, we did conclude that the single-family room, well, actually, that the combination that we had, because we obviously didn't look specifically, we couldn't compare all single-family to all open bay because the nursing staff actually works in both now. But we do believe the single-family room design does offer benefits, and that's based not only on our study, but also in some of the literature that you've referenced as well. And what we found really were that all of those fears that the staff members expressed, we asked them too on the post-move survey, were your biggest fears realized? And almost all of the respondents said no. So we really would recommend. I do understand though how some folks could say, well, we just can't afford it, or we just don't have the room, or our campus is just too small. There's no available space to do it. So I can sort of understand that, but based on our research, single-family room is the way to go.
So they did have a lot of fears. What design features do you think really made the difference?
Well, I think the wireless staff communication makes a difference. Also, they monitor the infant's vital signs. They can monitor those from that central nurse station as well. And then I think the decentralized stations with the window where you can view in and look at the infant, quickly if you're walking down the hallway. So I think those are all helpful. Um, if we could do it on just a brand new project with no restraints, I would love to see greater visibility from that central workstation, so that they could, the nursing staff could see the infants, more of them from that location as well. And I gotta tell you, Bob, one of the things that came up was that, and this is true. I mean, this is what has happened, is that sometimes a baby may spit up on itself or yank out its IV and get blood on itself. And sometimes the parent might show up and find that before the nursing staff does. So that actually is one of the challenges that they expressed, because they want to see it first and respond to it and make sure that baby gets very prompt care. So I think anything we can do. Actually, when I spoke with the clinical manager, she did say that having video monitoring at the central nurses station for each of those infants would probably be very helpful.
And I think that is where we're headed in the future, that continuous video monitoring of all patients, not just newborns, but in other parts of the hospital too. One of the major ways to prevent falls in older patients is to have continuous monitoring to see if they're trying to get up and go to the bathroom. So I think that's going to be a safety issue that we will see throughout the hospital and definitely in the NICU.
I agree.
So let me go back to some questions. We have a lot of good ones for you.
Oh, boy.
Stephanie Leventhal asked a procedural question about the study. Do you think the nurses' perception of the new space was influenced by their participation in the questionnaire? If so, were they more critical or more appreciative than the staff who had not been surveyed prior to the new construction?
Oh, boy, gosh, I'm guessing here. The hospital had very little turnover in the unit. We had a 55% response rate to the survey initially. So at least half of them did not respond to the survey initially. So I think that kind of helps alleviate some of the fear that maybe taking the survey caused some sort of bias on the part of the participants. However, I also noticed that our post-survey response was much lower than the pre-move, and part of that, I believe, is just whether or not the survey, the pre-move was more to a captive audience than the post-move survey. But I also think the staff members felt like they had input, they had the ability to provide feedback pre-move, but then once everything was, they were moved in, not really much was going to change for them. So I think that actually affected our response rate post-move. I could be wrong, but that's what I think.
Okay. Christopher Davis asks, were any of the rooms sized for multiple infants to accommodate twins or triplets, or what did they do when they had multiples?
I I believe, I should know this, but I believe the answer is yes, there were rooms for twins and triplets. I cannot recall how many, but I know that typically when we design a single-family room NICU, we do include rooms for twins or triplets. And Bob, actually, I know that you guys are opening a new NICU in the not-too-distant future, and have actually, well, explain that a little bit, because I think that's interesting. It'll be interesting to the listeners about how you're, going to accommodate the twins and the triplets in an open bay sort of option.
Yeah, so this is my current thinking. It changes every year, but at the moment, and now we finally have a chance to actually do it here, so I got to actually commit to it. I think our plan will be to have mostly single-family rooms so that every family who wants one can have access to it. We will have some twin rooms, which, as you mentioned early on, aren't that much bigger. You talked about semi-privates rather than privates. For twin rooms, if you only have to give space for one family and you only need, they're considered open bay if you have two beds, so you only need 120 square feet clear rather than 165. You don't need, so for a very nice private room, you might need 250 square feet, and for a twin room, you might need 300. You can provide those pretty easily. So we will have several of those, and that's based on looking at many year statistics about how many twins we typically have in our census. Then we'll have a couple of 4-bedrooms that can be used either for triplets or quads, which we don't get very often, or for unrelated infants, because there are babies whose families never visit, and if they're put off in an isolation room, a study out of St. Louis just recently has shown that their verbal development is impaired by that. So we want those kids to hear human voices that they wouldn't if their families weren't spending time with them. And there are a few families who prefer to be out in the open space themselves. You certainly identified that the vast majority of them at Joe DiMaggio want a private room if they can, but there are a few exceptions to that, and we want to be able to accommodate that as well. One final adaptation that we're going to do is that even in the private rooms, our head walls, our workflow will be set up so that in any of those rooms we could take care of one critical or two intermediate babies if we got to a high census area. This NICU is going to have to last us for another 25 years, and we don't know what the census needs will be down the road, and we'd like to be able to sometimes, if we had to, put two unrelated babies together in the same room in a high census situation. So that's maybe the best of all worlds. We'll see.
Good luck with those parent demands. I hope you do have enough single-family rooms for everybody who wants them, because otherwise you're going to have some headaches, I think. You brought up actually a point that made me think about something else that at Joe DiMaggio, and that is that originally the and it's different hospital to hospital that have these sort of combination NICUs. Some of them place the sickest infants in the open bay space, thinking because their coworkers can help monitor. But there are others who place the sickest infants in the single family rooms because of that whole developmental care piece and how important that is. So I wondered if you had any insight onto how that's working. I've seen about half that I've talked to doing one and half doing the other. So what has been your experience?
Yeah, so there's good data on that. Both the unit at West Virginia and the unit at Stockholm showed that the more mature babies, the babies over 30 or 32 weeks gestation, there was no significant difference in their outcomes between the two types of rooms. But in the more premature babies, those are the ones that really showed a major benefit from being in those rooms. So there's no doubt in my mind that it's the sickest babies who need this. They need that control of the environment. They need the best opportunity to have extended intimate time with their parents, and skin-to-skin care has been shown to occur more frequently in private rooms than out in a big open area. No surprise there. So I understand the reluctance again of staff, but we know it's safe. We know the babies do better in the private rooms. The sickest babies are the ones that, if you have to triage, they're the ones that ought to go to that space. I can tell you that our plan, again, is kind of based on a 90-10 philosophy. We will have enough private rooms and twin rooms, which are still single-family rooms, for 90% of our census needs. We've been tracking this for several years now. And there are some places that are more unstable than South Bend. South Bend's population has been pretty stable. But we know that the rooms that we build, 90% of the time, every family wants a single-family room and will be able to get it. And there will be a few high census times where some families, that may not be the case. And our choice will be to put kids who are probably going to only be with us for 2 or 3 days. A kid with hypoglycemia or jaundice, for example, might be one that ends up in the open area. But I think that's the most economically responsible way to plan for it, rather than to plan for 100% availability of private rooms no matter how high one's census goes. Because then you're doing all private rooms and you don't allow for some of the situations like triplets or quads or babies who really need to be out in an open area and hear some human voices.
Do we have some other questions there, Bob, that we need to look at?
We do. We've kind of anticipated some of them in our discussion. Angeli Joseph asks, were you able to evaluate any differences between the open bed and private rooms in the new unit? So your survey was nurses who were working in that combined area. Did they give you additional sense than what you've already told us between the two spaces?
Wait, I'm sorry, I'm being slow here. Could you restate that a little bit? I'm not quite sure.
Okay, so your survey just talked about overall impressions of the staff in the new unit. In your informal discussion, you got some sense of differences between the open bay and the private rooms once they were in that setting, but you weren't able to report that in your paper. Do you have any other insight on nursing attitudes between the two spaces?
Got it. Actually, no, that was pretty much the biggest thing they had to say to me during this informal interviews. Other than that, I mean, several of them said, oh, these single-family rooms are so much better for families. They're so much better for parents. And the staff is totally supportive of providing environments that are good for breastfeeding, and as you mentioned, the skin-to-skin contact and those kinds of things. But other than that, there were no sort of surprises or additional insights that weren't published.
Okay. Melissa, I'm going to mispronounce your last name because the print is so small. It's Pietkowski, I think. Melissa Pietkowski asks, in the survey and or the informational interviews with staff, did any issues arise regarding staff fatigue and walking distances? And if so, what were your findings?
We did have a question on staff fatigue, actually. Now I'm going to have to cheat and look really quickly at that particular question. Okay, yeah, so job makes me tired was the gist of that particular question. And in fact, there was a statistically significant improvement in that particular question. So they actually didn't feel more tired. They actually felt less tired in the combination unit as compared to the open bay, which is kind of surprising, actually. But
yeah, because I can tell you, I mentioned earlier, everybody's going to walk more in a new unit, whether it's open bay or private rooms, because it's it's going to be bigger. The square footage requirements are greater in the standards, and so that's going to be the case. But I did see a paper recently. It was rejected for publication, so I can't say where it was done, but they did put pedometers on nurses and respiratory therapists and residents and showed that they all did walk more in the single family room area than in the open bay area. This was another hospital that had hybrid where they had an old open bay area and added the new private room area. So they definitely do walk more. What I tell our nurses though when this conversation comes up is you're still going to be walking less than nurses anywhere else in the hospital. Our rooms are still going to be closer, smaller than what every other patient in this hospital gets. So you won't have to walk as much as any of your colleagues elsewhere.
Well, and Bob, don't you think too that part of that not feeling more tired in the bigger space may have something to do with the reduction in distractions, the more calm sort of feeling that we have in the single family room environments. I think there's so many other factors contributing to fatigue than just walking distance.
Yeah, you're exactly right. I've had a couple of neonatologist friends say where they used to have to escape from the NICU so they could just find a quiet place to relax, they now go to the NICU because it's so calming. It's much quieter, and this wasn't part of your study, but that's been a consistent finding. I also think if the kids are doing better, they're having less apnea, if they're getting out of intensive care quicker, if they're spending more time in the arms of the parents, the nurses have less to do in that regard as well.
Good point.
Maureen Haddock asks, what would you recommend to alleviate the fears that the nurses have prior to moving?
You know, the very best thing is touring another similar unit. So if you're going to a combination unit, I would suggest touring a combination unit. If you're going all private, I would suggest touring all private. Now, that may not be economically feasible, but with technology, certainly we can, you know, do more of a virtual kind of tour as well. And I think that it really helps. I talked with one nurse who moved actually to Minnesota and went from an all open bay to an all single family room. You know, Etch was the nurse here at Joe DiMaggio. And she said once, you know, after she got there, it was a little bit awkward for a while, but then she was a true believer in the single family room concept. So I think that the nurses have to talk to other nurses about it, and really brilliant neonatologists like Bob who can convince them that in fact it is going to be a better environment for them as well as for the infants and their family.
Yeah, and so we have a lot of data out there, and your study adds to that people can read and see that, in fact, this is not something that is to be afraid of because other people have been there, and here's the results of their experience. I would add that one important strategy is to change as much as you're going to change as you can before you go there. So the biggest problem, the biggest culture change, I think, between an open bay and a private room unit is usually this change in technology from where you are relying on your ears to tell you if a monitor alarm is going off or your eyes to tell you what's going on at a baby's bedside. And now you're going to have some sort of wireless device, Vocera or Emergen or something like that, that's telling you what's going on with your other baby while you're working with a baby in another room. And those changes don't have to wait until you're moving to a new unit and trying to find your way around and trying to understand this new communication system at the same time. So something like that could be introduced 6 months or a year before the move so that people are really comfortable with it when they get there. Okay.
Well, you just brought up an important point about this type of study that we conducted, and that has to do with the timing. How long do you wait before you do a post-move survey? Now, uh, sort of the general recommendation is at least 6 months, better if it's a year, because we don't want sort of that halo effect, or the, it's new, we love it because it's new and it's clean and it's bright. So we did wait 9 months. So perhaps, it would be better longer. But for folks on the call who maybe haven't conducted pre and post occupancy kinds of studies, I just want to be sure and get that out there, that 6 months is an absolute minimum that you should wait, but a year is probably more ideal.
Okay. Quick question from John Rogers. I'm not sure you'll know this, but I'll pose it. How many of the Joe DiMaggio patients are surgical versus medical?
Oh gosh, I'm so sorry. I really don't know that. I do apologize. Sorry,
Next
John.
one from Maria Urdaneta. How did you address med supply storage in each single-family room?
There are minimal, my understanding is that there are minimal supplies stored. Well, I mean, the basic, I don't know what percentage it is, what percentage of the supplies that they're going to routinely need that are in the room. We didn't use like a nurse server kind of system. And I honestly don't know what impact the new design had on FTEs, like you mentioned earlier, Bob, a supply tech, for instance, to make sure that all of those individual rooms are stocked. So unfortunately, I wish we had someone, from the hospital on who could tell us immediately the answers to those questions, so that gives us something to think about for future ones.
And so I'll give you my opinion on that. I think a supply cart that's present in each room that can be wheeled to whatever position around the bed is most convenient, so it gives you a workspace as well, is a great way to go for that.
Just curious, Bob, how many carts, what's the ratio, number of carts to patient rooms? Do you have a sense of that?
1 cart per patient.
One, so okay, so you have so the cart stays in the room. It's not something that goes between rooms.
Right. And in a 4-bed room, there would be 1 cart for each bed.
Right.
And that's kind of considered part of the patient care area, so you don't come to a cart and get supplies for 2 or 3 different babies and run the risk of cross-contamination. You keep a cart with each baby.
That's really important. You know what, that's something else that I didn't mention earlier as sort of the impetus for the single-family rooms, but in the adult populations, we have good studies that the single-patient rooms are associated with fewer infections in those patients. To my knowledge, I haven't seen a study, and Bob, you may know of one, that looks specifically at infection rates. We didn't look at any infant outcomes in our study, unfortunately. I mean, obviously there are limitations. This study was unfunded, and you always have limitations to every research study. But are you familiar, or is there anything that I'm not aware of regarding single-family rooms and infections?
Well, the one I referred to by DeMonico from West Virginia did show a reduced incidence of infection, but I think that has to be taken with a grain of salt. When you move from an old crowded unit to a new unit with much better HVAC and lots of other things that are better, whether it was open bay or single family room, I would expect a reduction in infection. Okay, we have a question from Carolyn Lee. Were mock-up rooms created to test the layout prior to construction?
I believe they were. I can't say with 100% confidence, but I'm pretty sure we did do mock-up rooms where a number of the staff members came through and made their recommendations on what changes they would like to see before the rooms were actually built. we typically do that, so I can't say with certainty that we did that on this project, but typically a project of this scope, we would do mock-ups. We've found that they're just invaluable and just so important to get
Yeah,
that feedback.
agree. They're essential. Okay, Susan Rackman asks, are there charting stations in each single-family room or just outside in that flyby station?
They are just outside currently. I know that some places are using, mobile wireless handheld kinds of devices in some places. So certainly I think that you could, as long as you have a place to set it down, and there's actually been some interesting research at Georgia Tech looking at the kinds of technology, but that's a really important question, concerning what type of technology do we use, because when you're charting on a computer or a tablet or something, you don't want to have your back to the parent. You may not want to have your back to the infant, but I don't think that really matters in this case. But it's really important where you're able to do that charting. So they have, like I said, they just have the stations there now, to the best of my knowledge. But there certainly are lots of options now.
Yeah, and for what it's worth, what we're planning to do with ours is all of the above. So we're going to have tablet option within the room that works wireless. We're going to have the charting station just outside each two rooms, which will be wired. And then we'll have another set of workstations at the central nursing area, so that wherever nurses happen to be, if they want to find something in the chart or put something in the chart, they're able to do that. Okay, we are, I think we've run through the questions. If we've missed somebody's, I hope it's because I thought we answered it as part of our conversation. We had a couple from Kathy Bejo, for example, that, Kathy, I hope we got answers to you. I'm sorry, here's one more from, and we'll make this the last one since we're getting close, and then give Sheila some time to wrap up. Melissa asks, how do you ensure objectivity as a researcher hired by the firm that designed the unit?
Oh gosh, I would love to have the luxury of a nice big fat budget to pay someone else to do research on our facilities. Oh my gosh, totally would be all for that. But given the fact that we can't, we had a very unbiased statistician at the University of Tampa, Dr. Ali Janzarli, and he took the data without really knowing what the intention was behind the design, and was able to do all of the analysis in a very sort of unbiased way, I do believe. Certainly, bias can enter in when you have a firm doing its own research, and there's no 100% fail-safe method for that, except getting external researchers to come in and do these projects. So, boy, if anybody knows of any nice little fat pots of money we could use, I know some great researchers in the field. I would love to hire to come do some research.
Okay, so both Sheila and I would be happy to answer any further questions. If people want to send them to us directly, you have our email addresses there. Sheila, do you want to kind of give us the take-home messages from your study and from your larger experience in this area?
Oh, wow. Well, I think a lot of what the focus on the single-family room that we really haven't talked about much today, though, is this issue of family presence. And we did do another study looking at family presence in the ICU, the adult ICU environment, and did find that the design was associated with increased family presence when compared a family-centered unit to a more traditionally designed older unit. But I do think that the whole family presence in this case with these frail infants is really important. You mentioned the verbal skills, the ability to, to hear these human voices interacting with one another, the physical touch. I can tell you, when my baby was in the NICU, I didn't do a lot of skin-to-skin contact. It was just very awkward, just, having this little thin curtain between me and the baby right next to us. So I think we want to get the family in there as much as possible. We want to make it comfortable. We want to make them feel welcome. Now, I do have one caveat, and perhaps if the family members have ever appeared on Jerry Springer, it might not be a good idea to have them present. But most of the time, I think it's really, really positive for the patient to have those family members nearby. So I am an advocate of the single family room. That's sort of my take-home message. If you can do it, and do it for all of them if you can. Perhaps with just some options for those triplets and quads and folks who may want to be in a more open environment. But the evidence just keeps coming in with the single family rooms coming out on top.
So let me reinforce that. The very most important thing for the babies is intimate human contact for extended periods of time. That's what has the biggest impact on their subsequent neurological development. And we can do that anywhere. In certain parts of the world, I went to an NICU in Madrid, there were 6 or 7 women breastfeeding their babies all at the same time out in an open room. No big deal. In South Africa, you're considered being punished if you're put into a private room. But in the United States, for most people, you are more likely to be holding your baby, giving your baby that neurological input that they really need. The incubator is not this wonderful, safe, sterile place that we imagine it to be. It's an inert, dehumanizing box. And for some babies, we need it. But where babies really need to be is in their parents' arms. And the single-family room is a very helpful way of facilitating that interaction and improving outcomes for babies. And the fact that families and staff like it too makes it that much better.
That's very well stated, Bob.